So the second discussion is about quality of life in patients with myelofibrosis. Obviously, as you know, quality of life is a real challenge in patients with myelofibrosis, a chronic condition with an impact on quality of life through several mechanisms listed on the left of this slide. Cytopenias and anemia obviously is a clear factor, constitutional symptoms, and splenomegaly that is often symptomatic when it starts to grow. And you can see in the middle of the slide the data from the International MPN Landmark Survey, which enrolled more than 170 patients from 6 countries. And you can see that for the patients, the most severe symptoms are inactivity, fatigue, depression, and all of them are very severe. On a scale of 0 to 10, you see that they are almost between 6 and 7 for these 3 particular symptoms. And on the right, you can see that for the patients, these symptoms clearly reduce their quality of life, and in more than 80% of the patients who strongly or somewhat agree with this statement. So it's clearly that improving quality of life is a priority in myelofibrosis patients. In addition, maybe coming from this survey, the landmark study, that there was not always an alignment between priorities for the patients and the physician, especially for physicians. It's half of them can choose watchful waiting, while patients are expecting some improvement and some active treatment to reduce their symptoms and improve their quality of life. In addition, you can see on the right that even patients with low prognostic scores have a significant burden of symptoms, 73% of them. Obviously, as you know, ruxolitinib changed a lot of things for our patients with myelofibrosis, and in particular, just to remind briefly, the COMFORT-2 results, the study that randomized ruxolitinib to best available therapy that achieved a reduction of spleen in 28% of the patients receiving ruxolitinib compares to 0 in the best available therapy arm, just underlining that we had nothing before to achieve this deep reduction in splenomegaly, but also the very good surprise was to see the improvement in symptoms. You can see on the right the mean change from baseline in symptom scores at that time, fatigue in particular, insomnia, appetite loss, and obviously on the right, to counterbalance this, we have to manage cytopenias due to the mechanism of action of JAK inhibition, thrombocytopenia, and anemia, who are usually manageable with dose reduction or transfusion, but maybe still a limitation. But still, these findings clearly establish JAK inhibition as the standard for symptoms and quality of life improvement in MF. I think we can all agree on that. And there are some evidence that maybe earlier treatment is associated with better outcomes. You can see on this slide the pooled analysis of the 2 COMFORT studies, COMFORT-1, ruxolitinib versus placebo, and COMFORT-2 that we just mentioned. And you can see on the left that patients who were diagnosed less than 1 year before starting treatment had better responses in terms of reduction of spleen volume, and on the right in terms of change in symptoms. These results are also durable. Several studies have shown that, and you can see here data from a JACOMO study, a long-term observational phase 4 study of efficacy, safety, and quality of life effects of ruxolitinib in patients with myelofibrosis. And you can see that the benefits are quite stable over time between month 1 and month 36, both in ruxolitinib naive or ruxolitinib experienced patients, although ruxolitinib naive patients had better responses. And then the impact of anemia. It seems that anemia can worsen some of the symptoms, although it's not evident for all of them. You can see on the graph here that anemic and non-anemic patients have sometimes the same level of symptoms, but still it's very important to improve anemia for the patient's point of view. You can see on the left, on the right, sorry, that it's really extremely or quite a bit important in the vast majority of patients. So anemia is also a concern for our patients and is associated with poor quality of life, obviously, especially not only by the symptoms, but also when patients become transfusion dependent. So to improve anemia, we have several approaches. Obviously, as you know, momelotinib is a good treatment, a JAK inhibitor that can target patients with anemia. This was shown in the Simplify-1 study on the left, but obviously in the Momentum study, showing clear benefit of momelotinib versus danazol, and that allowed the approval of the drug for patients with anemia and myelofibrosis. So this is a first clear option for anemic patients. We may also combine ruxolitinib to something else. Obviously, we use ESA that can improve anemia in these patients, but we have now also data from luspatercept, the phase 2 study. You can see on the right top, and the independence study, more importantly, that unfortunately didn't meet its primary endpoint, but Francesco Passamonti will show, I think, more details at the EHA very soon, so to explain maybe why the study failed and maybe the possible subgroup of patients who may benefit of this combination. Another interesting drug for patients with thrombocytopenia is pacritinib, which is not approved, as you know, in Europe, but used in the US, especially in thrombocytopenic patients. But sometimes we overlook the impact also on anemia. You can see on the right that in the PERSIST-2 study, there were clear improvements in terms of transfusion independency. And this is due to an inhibition of ACVR1, which is the same target that momelotinib. So although the drug is mostly targeted for severely thrombocytopenic patients, it may also improve anemia in this particular subset of patients. In terms of combination, we also have really interesting data coming from the MANIFEST-2 study. You remember that compared ruxolitinib plus pelabresib, a BET inhibitor, compared to ruxolitinib plus placebo. And you can see beyond the impact on spleen response and symptoms on the left, you can see on the right that anemia also was less marked than patients receiving ruxolitinib alone when the drug was combined to pelabresib. So this also may mitigate the induction of anemia that is associated with ruxolitinib therapy, especially in the first months of therapy. We also have other combinations that are still evaluated, selinexor and ruxolitinib. You know that there was this press release showing that the SENTRY study achieves half of its primary endpoint, and we will probably know more in the coming weeks or months. There's also a combination of ruxolitinib plus an MDM2 inhibitor, navtemadlin, and a combination of ruxolitinib plus novicertib, this PIM1 kinase inhibitor, which may also give us better results and improvement in terms of symptoms, provided that, like for pelabresib, the combination, the addition of a second drug doesn't increase the rate of adverse event. And we also have many other interesting strategies, especially for anemia. We have another TGF-beta ligand trap, which is elritercept, that may also show some improvement, just like luspatercept. We have hemojuvelin inhibitors that target the iron and hepcidin pathways. And obviously, we have more, let's say, specific therapies that are coming, in particular for patients with CALR mutation. We have these exciting studies with mutant CALR-directed antibodies, both from Incyte listed here and from J&J, and we will learn more, I guess, in the next EHA meeting of the results. And these new type 2 or mutation-specific JAK2 inhibitors, the idea is that we will have better responses without inducing anemia and without worsening the symptoms. And I think we will stop here for the presentation and open the discussion. These are some questions that have been prepared. The first one being, do you think that in your practice we have changed let's say, the gap between what patients expect from our treatment and the way we treat the patients and what we think are the main targets of therapy? and how we balance symptoms management with the underlying disease biology. How can the JAK inhibitor choice influence patients' outcomes, in particular in terms of quality of life? And the last question, maybe we can start with that. Are we adequately capturing quality of life in our real-world practice? I don't know if it's your practice to assess the quality of life of your patients using Rubens questionnaires or not, and if it's widely used in the community. But please feel free to comment on any of these points or additional points if you want.
Hi, Jean-Jacques. Can I start with a general comment? Congratulations for your presentation of the whole meeting. So in my practice, and I can report also in median Italian practice, we do not use questionnaire for evaluating the quality of life, but it's just reduced to a dialogue with the patient, asking him, what about you? What about your situation in general? So I know this is a limit, but when I think that in all clinical trial we use questionnaire, but in the real life, at least I think that's very, very rare outside the clinical study. Yeah. And another comment is that I think that we have partially solved the issue of symptomatology with JAK inhibitors such as ruxolitinib, and the result of the main phase 3 study of the combination ruxo plus something else more or less failed in terms of symptomatology improvement when compared to ruxolitinib. This means that we have covered part of the problem of symptomatology in myelofibrosis. Of course, not for all patients, but for the vast majority.
And do you now consider, you or others, of course, for the panel, the symptoms as a reason to start treatment in patients who otherwise don't have, the hard, let's say, harder endpoint that we measure usually?
Absolutely, yes, because in the course of symptomatology is very relevant for the patient, and in general is sustained by an excess of cytokines that have a role on many of the important events in myelofibrosis. So in my practice, yes, if the patient presents with symptomatology, I start JAK inhibition. If the patient have, of course, splenomegaly, at least these are the rules in Italy for the reimbursability of ruxo and other JAK inhibitors.
Very helpful. Juan Carlos?
Yeah, I've raised my hand, but just for saying the same as Francisco. In Spain, we don't usually use the Rubens scales in clinical practice. It's not common. But we are much more aware of symptoms, and symptoms are actually the trigger for initiation of treatment in many patients. So I think the gap between the perception of the patients and the doctors have decreased with the ability of these type of drugs.
Thank you very much. Another point maybe is what are your thoughts about the future of combination therapy? Because we have these at least 3 JAK inhibitors available now in Europe, and maybe 4 soon. And what will be the place of combination, and what are you expecting from this combination versus the JAK inhibitors we currently have?
No, I was thinking about whether we have to treat a patient just because of symptoms in myelofibrosis. One of the issues we are going to address with other people is the contemporary possibility to have with symptoms also some cardiac problems. One of this is the pulmonary hypertension. Pulmonary hypertension is a situation that could be frequent in patients with MPNs, particularly in myelofibrosis. One of the symptoms that are heralding a situation of pulmonary hypertension is the fatigue. So I wonder whether in the context of this question, that is an important question. I agree that the presence of symptoms can stimulate the doctor to give some drug. But in my experience, particularly in elderly people, we have to consider this. And maybe as hematologists, we do not pay so much attention to this. So pulmonary hypertension is a new chapter that should be introduced among our discussion on how to treat the patients with myelofibrosis, particularly, because in myelofibrosis, the most frequent disturbances that can be associated with the symptoms. Sometimes you miss this possibility.
No, that's very helpful. We always have to think for additional reasons for these symptoms and not neglect, to
Exactly.
make explorations to rule out some complications of the disease or associated comorbidities.
Yes.
Francesco, you wanted to make a comment? Sorry.
No, I agree with the great comment of Tiziano, because we have to remember these problems in our patient with myelofibrosis. Thank you, Tiziano, for remembering us the problem. Now, my general comment was on the combinations, and we see that most of these combinations were very useful for reducing the spleen. And this is important, especially in the setting of bridge therapy to stem cell transplantation.
Yes.
But if we exclude this setting that cover more or less 10% of the patient, 10-15% of the patient with myelofibrosis, I think that we need to have more data with a longer follow-up. For instance, in my opinion, it's quite important to maintain the spleen response over time. And so we saw that there is a reduction in the differences among the combo versus Ruxo in terms of SVR with a longer follow-up. At least this is what we have seen in the MANIFEST study. And I think that also anemia need to be improved.
Exactly.
We have information about this combination that, as you said, Jean-Jacques, can mitigate the anemia effect of ruxolitinib. The mitigation is probably not perfect, because you just mitigate but not improved. And I have a great expectation from the target therapy against CALR mutant, and also the new JAK inhibitor that seems to be very, very, very nice, at least if we see the EHA abstract that will be presented in the next 2 weeks.